It's my pleasure to introduce our two expert presenters today, Dr. Sarah Hetrick and Dr. Alex Parker. Both Alex and Sarah work at Orygen as Senior Research Fellows, and they're also both clinical psychologists that practice with young people who have depressive disorders. Sarah's published quite extensively on the treatments for depression, and she's currently an editor for the Depression Group's Australasian Cochrane Centre. Alex Parker is also the team leader of the Centre of Excellence at Headspace, and she has enormous expertise in how to translate research into clinical practice. And both Sarah and Alex are lead investigators on a number of major clinical trials that are being run at Orygen at the moment to understand what are the best possible treatments for young people who are suffering from depression and related disorders. So you're in very expert hands for today's webinar, and you get two presenters for the price of one. So without further ado, I'll switch you over to Alex and Sarah.
Thanks, Rosie, and thanks everyone for joining us today. I'm Alex, and I've got Sarah with me, and looking forward to exploring treating complex depression in young people. So today in the webinar, we are going to have a look at some of the challenges associated with treating young people with complex and also severe depression. And obviously it's a very in-depth topic, so we'll be just touching on some things briefly to get us thinking about things more and to help you think about things more in terms of how you might explore some strategies to tailor or adapt, particularly using CBT in treating young people with complex needs. But before we actually start with some content, we'd really like to start with a poll.
Okay, thanks Alex. So you can see our first poll question asks about how familiar are you with the National Clinical Practice Guidelines for the treatment of depression in young people? And you've got 5 choices there, not at all through to slightly, somewhat familiar, moderately familiar and extremely familiar. So feel free to vote on that now. And at the end of the presentation, we'll run through the answers to all of the poll questions, and you'll get to see how everyone else voted as well. Okay, we can see that the votes are coming in thick and fast, so that's great, and I'll hand you back to Alex and Sarah.
Thanks, Rosie. So we'll just spend a couple of moments just sort of really giving a broad overview about why we're focusing on this topic today and why it's important, and also why it's important to the work that Sarah and I do both in our research and our clinical work as well. So briefly, we know that depression is a highly prevalent disorder, and it's most likely to emerge in that adolescence or young adulthood years. And coupled with it being highly prevalent, it's also the leading cause of disability in young people worldwide, contributes to the most amount of burden associated with health problems in general for young people. And because of this, it also has really serious adverse effects on social and vocational and family functioning. You can see that there's a lot of disability or damage that can be created in friendship groups, in family relationships, and also just getting people off track in terms of where they'd like to be going with their vocational educational needs, and maybe not meeting the goals that they have, or having to deviate a lot or change and not being on the track that they perhaps saw for themselves before they became very unwell with severe depression. Also, we do know that it's really the early onset and particularly severe depression associated with high rates of completed suicide and suicide attempts, so lots of suicidal ideation and suicidal behaviours too. And that a chronic course is often associated with development of comorbidity, so additional problems, chronic course associated with increased suicide risk and also poorer outcomes overall. So all of those things combined, we know that it's actually a common disorder. It leads to a lot of disability, and we need to think carefully about how we work with young people to help them recover from depression. So the approach that we do take with our research work and our work at Origin is to really focus on early detection and early intervention. We think that that's critical to preventing a relapsing or chronic course of depression. One of the key predictors of good outcome is having a very good, well-treated episode of depression. It also then decreases the risk of suicide and also decreases the risk of secondary problems like the need for inpatient care or additional problems like that. To situate mental state in an attempt to try to match treatments to the presenting issues, and also taking into consideration the use of perhaps more simpler or benign interventions in earlier stages of illness, and reserving the more complex treatments for later stages of illness. And the model is also predicated on the idea that earlier and simple intervention may also prevent a young person from progressing to later stages of illness. But for the purpose of today's webinar, we actually will be focusing on those who are at stage 2 and beyond, so having had at least one episode of major depressive disorder with full symptoms and severe symptoms, and a lot of functional decline associated with that. So we'll focus on that today, but then, as I said, a lot of the other work that we do and that you can also find out about looks at those earlier stages of illness as well. So I'll just hand over to Sarah for us to consider what do we mean by complexity in terms of how we're going to talk about that today.
Excellent. So yeah, that's right. What do we mean by complexity? And we're really talking about a particular age group. So I guess it's really about what's going on with this age group. So we know that there's developmental issues that we need to consider. The cognitive development, and also what's happening socially for a young person and biologically in terms of their development. So that can add a level of complexity in terms of thinking about how those things might be interacting with what's going on with the disorder. Comorbidities, we know that depression is very commonly comorbid with other disorders like anxiety disorder, substance use, personality, that's up there. And that creates complexity in terms of dealing with a young person. I guess it's good to point out that often young people might not be presenting themselves, they might be referred by somebody, and so it might be that by the time we're seeing them, those kinds of things have started to creep in because it's been it's been some time since they've been recognised as being depressed. So the longer they're depressed, the more likely it is that comorbidities have arisen, but also that the severity of depression can increase, of course, if it's not addressed early. So the severity of depression symptoms is really an important complexity, and that's often where we can get a bit stuck, but issues like anhedonia, sleep disturbance and irritability indicate severity, but also are things to look out for in terms of, so irritability is something that we see in young people that we might not see in adults so much. In adults we'll be looking more for depressed mood, but it can be that depression presents itself as irritability in young people. There can be case management needs, of course, and that asking young people to think about a scenario or a situation and what their thoughts might be in that situation, but it's very difficult for them to think in that way. So that's something to keep in mind in terms of thinking. Abstract or hypothetical thinking, I guess, similarly is not there. That's what I'm sort of saying, that that kind of ability to hypothesize about things that are not tangible and right there. And they haven't had a lot of experience yet, so it's difficult for them to kind of think about possibilities, other experiences. Even putting themselves in other people's shoes is not something that's really easy for them to do at this stage.
About how things might be different for them too.
Yeah, because they never have been different. Perhaps they haven't got that experience. Yeah. I guess the other thing is that there's all sorts of things, of course, going on in terms of individuating. So, just go to the next. There's all sorts of things going on in terms of, becoming an independent person. So we know that the family becomes less important. Just rephrase it, I suppose. The family is very important and will be an ongoing support, hopefully, if things are going well in the family. But the relationship with peers becomes increasingly important, and potentially intimate relationships as well. But there's a lot about developing autonomy from the family, so it's a change in the relationship. And I guess young people are really aware of power differentials and this kind of seeking to be, a person in and of themselves. So that means that in therapy, we know CBT is a collaborative approach to therapy, but it's just so valuable to keep that in mind in terms of making sure a young person, feels that there's a genuine collaboration and a genuine ability to sort of direct how therapy goes. They're particularly concerned about privacy and confidentiality, and there's studies to suggest that that's one of the reasons that young people increasingly are valuing sort of text therapy and online therapy because of the privacy and confidentiality. But we can deal with privacy and confidentiality in face-to-face settings as well. And I guess, again, just thinking about individuating, it's that prioritising agency and thinking about how they have power in engaging in therapy with us. And I guess just to make the point that what's going on in terms of their development outside of the therapy session with their friends, with their parents, with their teachers, might be acted out, or we might see it in therapy.
Yeah. So what works for, Sarah will take us through a brief overview of what we know to date in terms of the evidence.
So by far and away, the most research has been done in terms of therapeutic interventions. Most of the research has been on CBT. There are some studies on IPT, and there's a body of research on other types of interventions as well. But what seems to be the case is that, that vast body of evidence around CBT, it consistently shows that there's a good effect of CBT. And in a review that I've recently been involved in with some international collaborators, they did a very fancy thing that actually statistically was a little bit beyond me, but it was called network meta-analysis. So it's a way of comparing different types of therapy with each other, even if they haven't been compared in a head-to-head trial. Mm-hmm. And as previous sort of literature suggested, again, CBT really came out on top, but IPT as well. So both of these are significantly more effective than control conditions. So that's why the guidelines, internationally as well as in Australia, suggest that the first, the line of therapy we should be using is with CBT and with IPT for mild to moderate depression. For more severe depression, or if the guidelines in Australia say if therapy is not available, then we might think about medication. And again, there's some evidence that medication is modestly effective, not overwhelmingly effective. The effect sizes compare well for therapy to medication. So I guess what is interesting though with the literature is that when CBT first was studied, there were really large effect sizes, and everyone was very excited about the huge impact that it was having. And as time has gone on, the effect sizes are actually smaller. That's probably to do with a few different things, some methodological things, but one of the things that's evident is that CBT is this umbrella kind of term for actually a really large range of micro skills and techniques that can be used. And there's been, like every trial you see, there's kind of almost a new version of CBT, or it's CBT that this particular set of investigators has come up with, and it might involve slightly different components. So each variation might have a slightly different mix of components. So we think that lots of that variation is kind of what's accounting for the more modest outcomes that we're seeing. And I guess we'll talk a bit more about this, that we really need to think about what it is within CBT that is not being done, that needs to be done, what the core components are, and just focusing again on what CBT is and can do, which is kind of what we're talking about today.
We will get to, yeah. Okay, so before we do, we'd like to ask you to fill in another poll to ask about your common, your therapeutic modality that you use the most.
Thanks, Alex. So here's the second poll question. What is your usual therapeutic modality when treating young people with depression? Do you use, and you can only get to select one, you might use many, but is it CBT, interpersonal therapy, third wave CBT treatments, supportive counselling, general psychotherapy, or other? So we'll give you a few minutes to vote there. We are aware that for some of you the webinar froze before. We apologise if that went down for you. But just to reiterate, the entire webinar is being recorded, so there will be the slides as well as the voiceover available, and we'll post this on the Origin website at a later date. So if you were one of the people that had the internet go down, rest assured it's all being recorded for you. Okay, and back to Alex and Sarah.
Thanks, Rosie. Okay.
So that this slide here is just a reminder of CBT. CBT is about the interrelationships between cognitions, thoughts, emotions and feelings, behaviour and action and physical reaction. So just a reminder.
Setting the scene.
And as I said, so CBT is complex, but I guess our point for this seminar is that the complexity makes it flexible. So we're not entirely clear from the research which bits work best, but we have got some hunches and some ways of working, and from some of the research that we've done, I think that can help us in terms of guiding which bits we do when.
And just to touch on very briefly about some of the myths as to why clinicians might feel CBT is not the treatment of choice for young people with complex needs. So first of all, that it's simple. In some ways, yes. I mean, some of the basic techniques are easy to learn, but then some of the techniques, some of the finesse comes into choosing then when's the right time to use them and how best to introduce them to young people and to keep them engaged. Some also too think it's just about changing thoughts, but again, we know that we have to situate that as being one of the things that we're targeting. So we're also looking at the changes in behaviours, the changes in emotions, and also the changes in how that might change some biological, like, you know, arousal in the body and things like that. So there's a whole network of things that we're looking at besides thoughts. That young people need to be psychologically minded to benefit from CBT is another myth as well. And it's certainly easier to grasp some of the concepts, I think, if someone's psychologically minded. But again, by teaching them teaching young people some careful monitoring techniques, also perhaps when starting with behavioural activation and they're starting to see the relationship between being more active and how that impacts on mood, it can help grow or develop some psychological mindedness
in a way
the process.
We're teaching them psychological mindedness.
That's right. That's right. So it's not a prerequisite that they to be able to do CBT. Again, in the last two I'll talk about together just briefly, that again this idea that it doesn't work for young people or that it doesn't work for complex or severe depression. Well, we know we've got a body of evidence now growing to show that it does work for young people. We know that it can, there are improvements to be made, but when you're thinking about that first choice about what to offer for a young person with mood problems, CBT should be the first option because we know that it does work for a lot of young people. And again, with the complex needs, though, we know that, you know, I mean, it's very hard because there hasn't been a lot of trials done with young people with treatment-resistant depression or very complex needs. But from the few that have also indicated too that the young people who've received the really skill-building components from CBT like looking at effective problem solving, looking at good communication and social skills tend to also have better outcomes as well. So again, it's about tailoring or adapting and picking the right bits of the therapy to use for that specific young person. So we will go through what we believe and have talked about as being part of the core modules of CBT. You can also find a lot of this information in a treatment manual that we have available now on the Origin website too. So if there's anything here that seems to be of use or could be of use for your clinical practice, you can always follow it up and have a look at the more information that we've got in the manual too. So these are some of the core modules, and we'll be working through these today, just in the sense of saying what do we know about how they work with young people and how we might think about adapting some of them to address those complexities we talked about before. So I'll start with psychoeducation. I'll start with our rough sort of session guide. So just in terms of thinking about how to work with a young person, to think about that first third of the session to be used as once you've actually started treatment, reviewing take-home practice activities and setting the agenda for the current session. So it's really important, I think, when using CBT to have quite a clear and, well, it can be to have a clear and structured approach, and young people sometimes benefit from that. The middle third, roughly, look at using that skill that you're focusing on for the week, and then the final third to sort of talk about issues that have come up during that session.
I guess just to say, with young people, in terms of thinking about agency and giving them power, that setting agenda is really good. And I'll say, this is kind of what I thought we might do today, but what have you got, and what's come out of your homework? So again, it's just handing power back over, isn't it?
Absolutely, and really reinforcing that collaboration. Cool. And now I'll hand back over for another poll.
Thanks, Alex. So this is our last poll for today's webinar, and it's asking about your confidence, especially in treating suicidal young people using CBT. So from your experience, do you feel not at all confident using this treatment modality, slightly confident, somewhat, moderately, or are you extremely confident using CBT with a young person who is suicidal? Thank you. We can see the votes coming in thick and fast on that one. So just a reminder, we'll show you all of the responses to the polls once Alex and Sarah have finished the PowerPoint presentation. Back to you.
Thank you, Rosie. So I'll start with talking about psychoeducation, and I think what we've come to realise too from a couple of the studies, but also from some of the work that we've been doing clinically at Origin as well, is that sense of how important it is to provide this and to provide it well at the start to set the scene for treatment. It gives the opportunity to help the young person realise that there's hope and some optimism for a good outcome. It also might help to address any stigma issues, whether it's self-stigma or stigma that's in their family or friends. So it can give them some information that they might want to take to their family to talk about what's happening for them, or a way in which they can communicate about their journey and what's led them to this point, and that makes sense. That can either alleviate some of the guilt that might be associated with it, or that the parents might be thinking that it might mean that they're not trying hard enough, or that there's or that parents have somehow caused it. So all of this information is really important in sort of setting the scene. And even just realising, for the young people who don't have much of awareness about mental illness or understanding what's happening for them, just knowing that there's a name for it, describing what the common symptoms are, and they can realise just knowing something they're experiencing is a symptom can be beneficial, and knowing it can be improved. So in all of this is sort of addressing the symptoms and the causes of depression, starting to think about that generally, and then tailoring it to their specific precipitating factors. Talk about what you'll do together in your treatment sessions, talk about the importance, if you're using a CBT approach, about engaging in doing the between session work, addressing that really early, and really trying to set that scene for that collaboration between the two of you in adapting the therapy for the young person's needs.
Yes, I was going to say, I talk about being a coach sometimes in terms of that collaborative approach. Is this, you know, I'm not, you know, we're going to be learning some skills that you'll take away, and you know, and we'll see what works for you, and you can come back, and if that skill's kind of something you grab onto, great, we'll go with that, and we'll try different things and see kind of what works for you in this journey. That's
absolutely. When we're thinking about then what might we do to adapt that approach if a young person has particularly complex needs, is again to, I suppose, to use that as an opportunity to address that interplay with depression, with other comorbidities that might be present for the young person, whether that be other mental health problems or suicidality as well, and just how that those are linked. We know that they're linked, and that sometimes just knowing that if mood symptoms improve, we might actually see a natural change or improvement in suicidality as well. Also to consider if young people have got some impairment with their cognitive functioning, either through problems with attention or concentration that are illness related, or just generally because of their developmental stage, to think about adapting or tailoring to make the information a bit more simple if it's needed to be. A lot of written information so they can take it away, have time to think about it, share it with their family or friends if they want to, and then bring it back. Always, you know, check in again that the message has been understood, or if they've got any queries, want to talk about it more. At that time too, if there's a lot of complex other things happening in there psychosocially, may even start to talk about the need of addressing some of those, to say what the role that case management might play in your treatment together. And then also too, if they're sort of reluctant to engage, maybe because again of illness factors, to maybe say, well, that again is part of, you know, feeling a bit pessimistic about outcome, feeling hopeless. That's part of, unfortunately, part of the symptoms of depression.
Yeah.
And sometimes I sort of take, you know, similar to what you're saying about being a coach, but I've never used that term in my head, but that sense of saying, you know, that to ask them to suspend judgment for a while and just see, to give it a go, and to trust that they might trust you as a therapist to give it a chance to see how things go. So building that rapport initially is really important too.
Yeah.
So along the way, we've also just included some quotes from a study that we have done, which hopefully we'll have the results published by the end of the year that we can share, but just from young people's experiences of doing CBT using the manual that we created. And so we did a small pilot study, and we got some feedback from half a dozen young people about their experiences. So we've just put some quotes in there. And so this one's specifically around psychoeducation here. You say that it was, you know, can see how it was really useful for them as a starting point for therapy. Some of the other young people also said just having that information that they could share with their families was also really important.
So the very first thing, I suppose, that we work with the young person on is really understanding emotions, and until we can, and a young person can really recognise emotions and understand what they are and rate the intensity of those and think about how they change, you know, it's difficult to do too much else, because everything, this is where we're kind of working, is at this on this mood. So there's no doubt though that a lot of young people can't describe or use, you know, they don't have a vocabulary for it. So it's really about developing that with the young person, and I guess there's ways of doing that. You know, there's emotion faces that people use. So there's even the emotion icons. Is that what you call them? Emoticons on phones. I'm not very techo-savvy. You know, that's a way of helping young people kind of just tease out what's the difference between being irritable, being angry, being frustrated, being sad, being down, being hopeless. Some of these things are sort of interrelated, but hard to kind of think about in the moment, and often that's the response you get, isn't it? So how did you feel about that? Oh, I don't know. Yeah. Or the other thing is they'll say, oh, I thought it was really bad. So, you know, and it's teasing out that difference between, okay, what are you thinking and what are you feeling? Those things are kind of different. So spending a bit of time kind of talking about that. I guess up there's the idea of using scenarios that they bring, or providing scenarios. Externalizing emotions a little bit. How do you think your best mate or your mum or someone else might feel if that happened to them can be useful. And I guess one of the the key techniques that we use is kind of mood monitoring. Would that be right?
Yes,
that's kind of always my first step. And I guess that can, I would never stop doing that in some ways, and it's certainly the first kind of step. And traditionally we've sent out bits of paper with, what's your mood, what's just happened, rate your mood, so on and so forth. And what of course is increasingly happening is young people are coming back with it all in their notes and in their phone, which is actually great because they can do it, often if nothing intense is happening right in the moment, it's difficult to rate. It's more easy to rate your mood when something's happened or you're feeling something quite strongly. So to have your phone with you, you're not going to have your piece of paper from your therapist with you, to have your phone with you can be useful. We've developed a tool here, a mood monitoring tool, which was online, and the feedback from that, so young people were using that to rate their emotions actually just when they were attending their face-to-face session. But the feedback from that was great in terms of, young people said that it actually was really useful in terms of helping them to, I guess, understand their emotions and also, in a way, almost control their emotions a little bit more. I guess they could understand that mood does fluctuate, and that's actually a really, maybe an important first step, is particularly for someone who's very hopeless and very depressed, to understand that actually there may well be some fluctuation. It's kind of like that we were saying, they haven't got this kind of huge lifetime of experience of knowing that mood goes up and down, but if you can even demonstrate over a week that actually there is a little bit of shift, I think that's really helpful.
That's right, and then that gives you that opening to then explore what's happening in that context of when the mood does slightly vary, even if it feels like at that point when they're describing it that it's always bad.
It's always bad, yeah, actually it's not always quite as bad. So that's what we do. We can think about intensity rating, so was it, we use a sort of a 1 to 10 kind of rating. But linking the severity of symptoms with kind of what's happening in that moment, what's been happening that morning, that afternoon. And a lot of young people said that that tool, using that tool was really helpful in terms of, for some young people, they found it easier to put their ratings into that than to talk about it face-to-face, so it was a way of providing information. So some tools like that can be really useful, I think.
That's right. So if there's something, obviously we're working on looking at towards making that the specific tool that Sarah's talking about more widely available in the future. But in the meantime, if it's about looking at some mood monitoring apps, or even, as Sarah's saying, as simple as doing something like the young person's putting in the notes function in their phone, or putting something in their calendar, so we can take the paperwork out of it, and they've always got their phones on them. So also, I had one client who had a lot of difficulty with even describing how they were feeling, so then they chose to actually take photos throughout the day of things that they felt were describing their mood. So there's a lot of ways that you can actually use the phone simply without it feeling like it's sort of taking over what you're doing.
Yeah. So this is, again, a quote from some of the qualitative research we've done, and just says, that just shows how important it is for recognising patterns in terms of what's going on between what you're feeling and what you're doing. So I think, that's what the mood monitoring is really about, isn't it? A, kind of, understanding emotion, but B, then we start to think about linking it to what's going on.
Yeah, absolutely.
So, and I guess it's that linking to what's going on, which leads us into behavioural activation. So CBT, when it was first developed, this was always sort of the first thing that kind of happened. And one of our hypotheses, or things we talk about a lot, is perhaps that maybe this technique is so simple that we've forgotten how powerful it is, and it's almost been lost. So when people talk about CBT, they're often just thinking about the cognitive pieces of it, the cognitive restructuring. But actually, you know, all of the techniques, I guess what we're aiming to do with CBT is change the relationship between behaviour, thoughts and our mood. And any of the techniques can change any of those other things. So we can do behavioural techniques and it will change cognitions. So again, we've already talked about, so if a young person can just see that actually their mood fluctuates, well then we've got a powerful way to kind of change that thought that nothing will ever change, it will always be the same.
That's right. Or if they engage in something with the activity scheduling or the behavioural activation that they actually can then achieve, then again they've got a thought around saying, well, improving their self-confidence or self-efficacy, knowing that they can actually do something. Yeah.
And sometimes those things are really simple. It's getting out of bed at 9 o'clock, you know, and having breakfast. And actually, but if you schedule that in and then you actually do that, then there's a real sense of achievement, and young people will report, oh, I felt much more motivated, and you know. So, I mean, I would always start with pleasurable event scheduling, and that might sound easy, but in fact, young people who are very depressed will not be able to think of anything that's enjoyable.
So it's always handy to have a checklist or some suggestions on hand.
Yeah. Or, you know, for example, in our manual, we've got some handouts around, well, what did you use to enjoy? What things did you use to give you a sense of sort of enjoyment or mastery? And, you know, and I think it's one of those things you do slowly over the weeks, things will kind of become evident or creep in, or, you know, on the spot, what do you find enjoyable is often a difficult question, and it sort of comes through conversation and kind of noticing what they've done during the week. Oh, so you spent time cooking. Do you like cooking? You know, that kind of a conversation. I guess I almost prescribe it, and I'll talk about it like that. I'll say, look, your psychiatrist or your GP might have given you medication. I'm prescribing a pleasant event or something enjoyable for you to do every single day, because this is, you know, it's like a happy pill. I don't think that.
Yeah.
But, you know, it's really, really important, and I guess it's important because hopefully it just gives that opportunity for some positive emotions to be experienced, but it does introduce this opportunity as well for them to notice changes in their mood and changes potentially in their thinking. So we're starting to work towards being able to get those links going. And we will always talk about, I always talk about this cycle of depression. So, you know, there's a lot of avoidance in depression, a lot of withdrawal and a lot of inactivity, and that just leads to further decreasing sort of more severe mood. So I talk about just sort of flipping it on its head, but, you know, taking very small incremental steps. You know, we're not suddenly going to be back to the life you thought you would have, but let's start with what is possible here and now, which might be getting up at 9 o'clock in the morning 3 mornings a week, and that might be all it is to start with, and making sure that there's something pleasant each day to kind of just stop.
So they're maximising those opportunities for success in this task.
Yes. Yeah. I guess so the complexity comes in with thinking about what other additional things are going on and what's going to make it difficult to do behavioural activation. So first of all, you know, kind of the anhedonia and obviously the hopelessness in terms of just coming up with pleasant events is tricky, but if there's any sort of social anxiety, difficulties with social skills, that's going to make it more difficult to schedule pleasant events that involve others. But we know that involving others in some of those pleasant events and increasing social activity again increases the opportunity for positive reinforcement and for increasing mood. So that's where you might need to think about, you know, again within a CBT framework, talking about, you know, exposure to anxiety is the only way to overcome anxiety, and some of the, you know, the cognitive techniques that you might use for social anxiety and social skills. And Alex will talk about some of the targeted modules that you might think about that you might need to pull in just depending on what's going on for a particular young person. As we've already said, it's focusing on small achievable steps. So for someone who's very depressed and their functioning is very poor, it is really, you know, it's really important to make sure that they're going to achieve what it is that they set out to do in a week, that it's not kind of overwhelming. You don't want to overwhelm them because we haven't started dealing with the thinking and that overwhelmed, you know, what happens in that sort of state. So you don't want to put them there. As we've got the self-care strategies, pleasant activities are really important, particularly for those who are suicidal. So this is really critical for them, I guess. And again, you know, when you've just started, you won't be straight into cognitive restructuring necessarily, but just increasing kind of distraction and self-care and self-soothing and those kinds of behavioural techniques for someone who might experience, you know, extreme distresses is really important for dealing with that in that moment. So I think the behavioural techniques are really so important.
Absolutely.
So just another quote there. So I did notice that I withdraw. It is just so common, isn't it? And you get into a cycle. Planning or trying to plan certain things was helpful. It didn't have to be much. Just catching up with someone for a coffee, watching a movie at home.
Yeah. So again, keeping it simple and matching to their interests. So another core component that we look at in terms of the approach we're doing with CBT is around chain analysis. And this is an idea of doing a real functional analysis incorporated within that ABC model. So what's the activating event, what's the thoughts or beliefs that are triggered, and then what are the consequences, behavioural or emotional, from that event. And for young people in particular who may have, I suppose, a poor understanding or some trouble understanding the relationship between their emotions and their thoughts and actions or events that occur, or just feeling like somehow bad things just keep happening and they're not sure why, this can be a really useful approach. So it's actually then looking at that chain of event that actually led to that event happening. So carefully going through those ABCs, finding out what were some of the vulnerability factors. So for some young people it might be that they know there's some pattern as to when they're tired or when they're substance affected, or if they've had a fight, you know, a fight with mum the night before or something, and then that sets the scene for something happening and a cycle continuing. If there's anything different happening that day, so what were some of the context factors that you can look at, and then really looking at that chain of events. So who were they with when this happened? Where were they? What was the weather like? What were they thinking? What were they feeling? And trying to even use a freeze frame method if that could be useful for them to get into the real nitty-gritty of what actually happened in that event.
So by freeze frame you mean, okay, let's think of it as a snapshot.
That's right.
That then and then the next
and you
snapshot.
Describe it. And you describe each of those snapshots as to what got to that end point. And by doing that, it then gives us that opportunity to actually say, well, now we actually know what kind of led up to that. How can we go backwards and look at various points along the way where we might be able to intervene or do something different, so you don't end up in that situation where you don't know how or why it happened, but something bad happened, like another huge fight with your boyfriend, or that you were self-harming or something like that. So all of those things. And so we can look at some things along the way, like self-soothing, self-care strategies, who else you might want to involve, problem-solving skills, looking at cognitions at a later stage, and general things around managing distress more effectively.
So we don't talk heaps about formulation, I guess, but I guess, you know, CBT is all about it, and formulation, and what we're talking about is picking, you know, that artistry of picking what to do when, and I guess the ABC chain technique is really important for starting to think about treatment planning, really, in some ways as well. Or informing your treatment plan.
Yeah. So again, you know, for those with really complex needs, with suicide, a lot of suicidal ideation, doing this can actually assist in that crisis planning, so developing the risk plan.
Yes.
And it also just gives that sense of just really understanding how distress or intense emotions can actually lead to an event occurring, or how it contributes to an event occurring. And then knowing that there's some ways in which you can manage that intensity may then make that event less likely to occur in future.
And I guess it also gives, again, we're just sort of talking about that sense of control. So if young people, you know, through this process might, instead of just feeling like things are happening all the time, I'm in this suicidal crisis all the time, actually it just brings more of a sense of control in terms of seeing how things might have led to that. And I think, you know, so one of the other studies we've done, we've got it's an online intervention, CBT intervention for suicidal young people, and that chain analysis is really important in terms of the safety planning and thinking. But what we really sort of emphasise is this idea of a trigger point and understanding the emotion and the intensity of the emotion. So again, it goes back to that mood monitoring and understanding emotions and intensity of emotions, and thinking about the trigger point and what the other things are that then, you know, impacted on that or caused that. So
absolutely, so you can sort of see, how these things build on each other when you're working with a young person. I think too that sense of being able to see that we might not be able to control or change a situation, but we can also start to see how we can change the way that we might respond to it. So
or better prepared for it as well.
That's
or,
right.
You know, if we're tired and this happens, we're not going to respond to it as well. But if we make sure that we're, you know, looking after ourselves in other ways, or have things to look forward to as well. So again, so bringing that pleasant event scheduling in, well, I know I've got this really stressful thing coming up, and this is often what will happen, but actually I can do some self-care things on the way to that, and actually if I've got a reward to look forward to where I know I'm going to go and meet my friend and have a coffee or something afterwards, that's something to sort of look forward to and get me through that.
That's right. Break the existing chain and do something different. And then also too, for young people, that last point is really addressing the young people who might be really reluctant to engage in therapy overall, and just that idea of saying it can actually, using chain analysis might be a useful technique if using the idea of just, you know, getting mum and dad off my back about things, you know, mum and dad think I need therapy, I don't really, but then we say, well, what might need to change to get them off your back, and what happens when you actually get into that cycle of arguing about things. So it's just a useful technique that difficult to engage young people might find easier to engage in. So for this young person, particularly knowing how to break the chain, so knowing when you feel like this, how can you react differently to the feelings and then counter it and create a new chain, so a new outcome. So it can be really quite a powerful technique.
So here we get to, I think, what people often think of as CBT, but you know, as we've sort of gone through, there's so much more before we get to this bit, I think. And I guess the first point is really to say that perhaps think about not moving on to this until you've really consolidated those earlier skills. And as we've kind of mentioned and maybe alluded to, but I'll make it explicit now, you know, some of that mood monitoring and the behavioural activation, by engaging young people in that and getting their feedback, you know, about what's happened, looking through their mood monitor, and that's actually where you can start to get into their thoughts and identify some of the thinking that might be going on. So we, you know, as we've got there, we might just add to our mood monitor. So we've got a handout, again, which we prefer not to use in terms of paper with young people. Some people like it, but it's just adding a column, really. Okay, so we've thought about what's our mood, you know, and what have I been doing. Now we just start to encourage young people to think about, well, what might I be thinking? And you would have done this in session. I think it will have come up in session, because it can be tricky otherwise if you haven't gone through this. But it's really beginning to get the young person to think about what's the thinking as they're doing things, and that emotion is there. I guess it's highlighting that automatic thoughts are just, you know, that's just, there's always thoughts going on, and it's really that, you know, that's fine, but some of them are helpful, some of them are not, and that they can also, you know, those unhelpful ones, you know, might be reflective of long-term beliefs, and that might be what's sort of underlying some of the behaviours that are not working well in a sort of leading to the mood that they're experiencing. It is really critical, this piece, I suppose, for those with suicidal ideation. You know, that in and of itself, suicidal ideation is a thinking behaviour. It's all thoughts. It's thinking about you know, wanting to die. So, you know, being able to identify those thoughts and is really critical for those with suicidal ideation. And I think in the study that that I mentioned, it was this piece of restructuring that actually young people found really helpful. And it, you know, it's just disrupting. It's just identifying that that thought's even there and disrupting it a little bit, and thinking about whether there's just a little bit of flexibility that you can introduce to that thinking, I suppose. So I guess the thing to just be aware of, though, as well, is that actually sometimes for young people, focusing on the thinking might be distressing for them, because they don't want to sort of stay there with the thoughts, and it's difficult to restructure them, particularly if you're butting up to kind of beliefs, I suppose, and that's really critical for a therapist to be thinking about, are these unhelpful sort of automatic thoughts, or we're starting to get into some sort of core belief here. So again, just to remember that actually it might be recognising the thinking, but actually going back to some behavioural techniques and some distraction activity scheduling might be more useful. So and we've got some other things up there. You might spend more time on behavioural activation for someone whose cognitive functioning is impaired. And for those with poor functioning, particularly if you want to get them back on track in terms of school, and that might be also what they've come in with. Actually, I just want to get back to work. How do I get back to work? You know, no doubt there's some thinking things that will get in the way, and that can be introduced perhaps subtly by using the behavioural techniques rather than kind of going straight for a cognitive technique alone. Actually, using your behavioural techniques to just gently help a young person identify the thinking that might be getting in the way of what they're trying to achieve.
But also for them to have that opportunity to experience some change in how they're feeling.
Yeah.
At the same time.
Yeah.
So yeah, to better engage in thinking about those thoughts. Yeah.
Yeah. Yeah. Yeah.
And I think, and that sense of sometimes for those, the more monitoring that we do around identifying these automatic thoughts, as Sarah's saying, sometimes can feel very overwhelming for young people, and they get caught up in this sort of daily dysfunction rather than then seeing how it's going to be of use. So I think carefully also describing the rationale is always important for all of these approaches or modules that you'd use with a young person, as to why we're doing it, even though it may be hard, and the outcome that we're hoping for.
Yeah, I guess there could be some avoidance as well, isn't it? I just don't want to think about that, because thinking about that is what, you know, that's what's got me here. So it is sort of a gently approach, and we don't want to collude with avoidance, you know, but thinking about how to do that carefully.
Yeah, that's right.
So I guess, you know, this is again one of the quotes that breaks down those thoughts instead of it being just one chunk of negative thoughts, and I think that's true, isn't it? It can just be like, oh my gosh, it's just so overwhelming, but actually if you break it down into the individual thoughts, that's I think what this young person is saying. I didn't realise there would have been different types of negative thoughts and different ways of dealing with them, so this one was really helpful.
Yeah. So on to the last core module.
So, you know, this is what we're kind of leading to in terms of you can't really work with unhelpful thinking unless you've identified it. So even though it might be difficult to identify, you've got to get that in terms of be able to work with it. But I guess we're then getting into your very classic kind of cognitive work where you're challenging it. And, you know, probably everyone's familiar with the typical sort of techniques of, you know, when we're getting into cognitive restructuring, so evaluating evidence for and against, generating alternative explanations, what might someone else think about that if they were your friend. Sometimes it's just the advantages and disadvantages of keeping that thought, so it might not be that you can do much with it, certainly to start with, but actually just kind of again introducing some flexibility. So, oh, maybe that's, you know, maybe it's not true, or actually that thought's there, but actually if I buy into that, that's not going to help me today. It's not going to help me to get to work today, so actually maybe I'll just leave it. challenging the cognitive distortions, so you would have spent some time potentially going through those, or you might introduce it as they arise, that all or nothing thinking. That's a really useful one to disrupt. Actually, it doesn't have to be all good or all bad. Maybe it can be good enough. Some thought control techniques. And creating distance from thought. So I guess there's a little bit of mindfulness in that, isn't there, where it's, again, it's not kind of going for the restructuring, it's just, oh, there's that thought, you know.
Yeah, and that difference between thoughts and or beliefs and truths or facts as well can come into that
that's
too.
right. I guess that's right. Yeah, that's it, isn't it?
Yeah.
So I guess in terms of working with complexity, again, it's just to reiterate that it might be that it's just a matter of really introducing some flexibility to the thinking. So we're trying to integrate core beliefs associated with comorbidity, so the world's a dangerous place, and you know that might take a long time to sort of shift that, but I guess introducing this, you know, that's a belief that I hold that may not be true. There's just a little bit of flexibility there. It gives you some room to shift. You know, and exploring that idea of good mental health as being something that is about that cognitive flexibility. So again, we might not, you know, core beliefs, things that have been there for a long time, we're not going to shift those in 6 sessions of CBT necessarily, but even just being able to have, you know, some doubt about that.
Or being and having that awareness that it's a belief rather than it is a truth. Yeah. Yes. And sometimes that can be the sort of breakthrough moment for those who have severe or complex needs.
So again, another quote, I think it's important that people challenge their thoughts, because otherwise if you don't challenge them, then you don't know, you know, what stops you from thinking that, you know that it's true, so it's important. So young people really endorse this as something that's useful.
That's right, and consistent with that second quote too, from some other very small qualitative studies that have been done to just sort of ask some young people about their experiences of having CBT. They do also say that the cognitive restructuring part is really hard, but they really see the benefits from it. So it's sort of that sense of saying that they know that they can actually work really closely with their clinician to actually do that hard work together.
Yeah, well, even on the online for our suicidal young people in that trial, our sort of qualitative feedback, you know, again, it was the cognitive restructuring as well as problem solving, but the cognitive restructuring was up there as hard but really useful, one of the most useful things. Yeah.
So again, we sort of alluded to this, but that sense of, you know, with the complexity of an intervention like CBT, that where you can bring in your clinical knowledge and your clinical judgment, and working with every individual young person and using a formulation and addressing their specific needs, you can actually, there is some artistry in CBT, knowing how and when to choose the techniques to work with that young person for what they need. Very briefly, I'll mention that we've got some additional sort of targeted modules in the manual that we have prepared, and again with this idea about being flexible. So depending on what the young person's bringing with their presentation, that looking at additional modules around distress tolerance, safety or risk planning, self-care strategies, when substances may be involved, and then also some things around specific skill building and also looking at managing anger. So we've got all of those modules as well, which obviously today we haven't had the time to get into, but again about picking or adding in some additional factors if needed depending on what the young person wants to work on and what you decide to do as important.
Formulation is, I guess, in terms of, you know, understanding the complexity and the needs that they bring, and kind of what you start to put this picture together of what might be going on.
Absolutely. And again, just finally wrapping up with relapse prevention. So again, to be thinking ahead when you're working with the young person, because we know that ending therapy can be very difficult, so to be mindful of that as you're working along. It requires careful planning, but to review all those skills that they've learned along the way around mood and symptom monitoring, identifying early warning signs of what might happen with some of those thoughts or beliefs that they have. If they know that they're intensifying, perhaps
how will they know?
How will they know?
Better, worse,
and what can they do? Who can they ask for help? Who can they look for support once therapy's ending? Really reinforcing those self-care strategies that they've learned along the way of managing distress in a better way than perhaps that they were originally doing.
I guess it's reinforcement for them, as well, as you're going, that, wow, look at this, you've learned this skill, you've found this really helpful. And I mean, often some of the, settings that we work in, young people might only sort of turn up for 4 or 6 sessions. They might not give you warning about when they're going to end.
Yes.
And so actually I start talking about relapse prevention sort of in a way quite early on. So I'll talk about, like, as soon as I notice that something's been helpful and is working for them, I go, look, this looks like something that you really learnt really well, that's working for you, you like it, don't you, practicing it all the time. This looks like something that you should, we might start thinking about a wellness plan, and maybe we should start jotting down the things that, are working for you.
Yeah.
So you can start thinking about relapse prevention right from the get-go, really. Yeah,
absolutely.
So I guess we're just sort of getting towards the end, and we just wanted to highlight sort of from some of the research that we've done and been involved in, and also from some of the literature, that young people, do like CBT and do find lots of it really helpful. And I guess the list there, it almost seems as though they find all the different bits quite helpful, and it might be that different kind of presentations prefer different bits of it. So this is just, we've pulled it all together. But suffice it to say that young people, they can be well engaged in CBT, and from the qualitative stuff that we've done and read about, they do seem to like it. They do become engaged. They are able to develop a relationship with the therapy. Like you pointed out right at the beginning, they do quite like a clear plan and the structure of sessions. Kind of, I guess that's a little bit about giving ownership and agency. If they know what's going to happen, they feel kind of safe. I mean, we all feel better with boundaries, don't we? So knowing what the boundaries are and how things are going to go and what to expect. It's a pretty unusual, artificial kind of thing to do, engaging with a perfect stranger face to face to talk about your problems. And and there is some research to say that that's quite uncomfortable for young people. It's probably quite uncomfortable for adults, actually. Yes. So it's an unusual thing. So I guess the more you can kind of give education, and this is how it's going to be, and make them feel comfortable, the better. Yeah. As Alex said, the cognitive stuff can be, the most helpful, but it is the most difficult. But I think the more you kind of work on those early skills, so they might sort of say, learning to identify my emotions and my thinking wasn't that helpful, but actually you need those skills to be able to do the rest of it. So psychoeducation can be really powerful, and they like that. And I think particularly in terms of undoing the stigma and understanding that this is not that this is an illness, and this is why I can't get myself up and go to work, not because I'm useless, but this is what the depression is doing to me.
Normalising
it and giving some hope. Social relationships and skill building, that comes up a lot, doesn't it? In terms of just dealing, there's such a lot going on interpersonally with young people that I guess dealing with some of that stuff can obviously be important.
Okay, so just to then wrap up before we go to some questions, we just really wanted today to be able to touch on that importance of considering the developmental considerations with young people, about the developmental stage with they're at. We're looking at dealing with such a broad range of 12 to 25 years. There's a lot going on during that period, and just keeping in mind those impacts of like development with executive functioning and all those sorts of things, how they interplay with how they can connect with the therapy. And I think too, just about what we can do with those core modules of CBT to match them and pace them to the young person's needs. And that's where I suppose we haven't really touched on, but just to embed it with this idea of it all being around that, addressing the formulation that you've developed from your assessment with the young person and knowing where you want treatment to head.
Yeah, that's right. Yeah, I think, like I say, we haven't touched on it, but presumably it's part of what everyone's doing is that formulation of kind of why is it that this young person's here and now, and kind of what's led up to it, and then the ABC analysis around, you know, some of the things going on in the right here and the right now, because CBT is very much right here, right now, but it speaks to, and you know, your formulation will think about what's happened in early life that's kind of created assumptions and beliefs and so forth that might be triggered in the here and now. You know, but your formulation will also think about what's the functioning like right now. We'll think about what's the, you know, cognitive abilities like right now, what age, what's the severity here. Where's the best place to start? You know, probably somewhere simple with someone who's got a lot of complex needs and severity.
Yeah, absolutely. So just before we do finish up, we'll just talk about that, as I mentioned, you can find the CBT manual that we have, that we've written here at Origin through the combination of researchers and clinicians, and it's available now if anyone's interested in having a look. You can find it on the Origin website. So it contains the core modules that we talked about, the targeted modules that we touched on very briefly, but also a whole series of worksheets and handouts and activities that you can do in session with young people as well. So we're hoping that it can be really useful for clinicians out there. So that brings us to the end of the information that we wanted to share with you today. And so now I think that we have the opportunity to take some questions and to respond to some of the questions that you'd like to ask us.
Thanks, Alex. We've had a number of questions come through. Before we get to them, though, we'll just run through the results of the polls so everyone gets to see how everyone else voted. So there's the answers to the first question about how familiar you are with the National Clinical Practice Guidelines. And pretty interesting results that the majority somewhat familiar, and almost 1 in 5 of you have no familiarity with that one. So that's interesting that those guidelines obviously need to be disseminated to practitioners like yourself. What is your usual therapeutic approach when treating young people with depression? Again, very interesting. So we were preaching to the converted, most of you using CBT, but a lot of other approaches. Interesting that IPT has such low numbers, given that there's an enormous amount of evidence for its effectiveness. So there's something happening there with young people. And the last one, how confident are you in treating a young person who's suicidal with CBT? And again, I guess that the majority, at least some reasonable level of confidence. So that's an interesting one, but 1 in 10 of you not confident at all. So just a reminder that when the webinar closes, we have an evaluation survey where you can just give us feedback about today's presentation, but I'm about to reveal myself again and run through some of the great questions that we've had being posed to Alex and Sarah. So there have been a number. Hopefully we can get through a majority of them. The first one is a good one. How do you deal with young people who simply don't complete homework or between session activities?
Mm-hmm. Who would like to go with that one?
How do you deal with that?
Well, I think it's a common issue, and I think that one of the things is in part of that initial engagement stage to actually talk about it right up front as being an important part of treatment, and to think then about whether it is about it not wanting to do paper-based stuff. Is it about the modality? Do we want to change and see whether they'd be happy to do it if they could actually track some things in their phone or using an app instead of paper-based stuff? But also I think too, just highlighting that thing of saying that what you're doing in session can only have maximum benefit really of when they actually experiment and try it out in between.
Yeah.
So it may again be about not wanting to actually write things down, not actually wanting to track, and that's okay because you can do that in session. But if they're still willing to actually do some of that experimental work between sessions, I think that's the key to focus on.
I guess that's where you might be thinking about avoidance, and is there some more problem solving that we need to do to think about, are there some difficulties and what those might be in terms of doing that thing that you're wanting them to do. So, I mean, you know, a simple example of someone who actually has really severe social anxiety, so you might have set them a task to do X, and actually what you don't realise perhaps at that point, because things are always evolving, is that there might be some kind of really severe sort of social anxiety that means they just don't want to go out down the road to get a coffee. Or
absolutely, or thinking too whether some of those cognitive components are coming into play as well, where it is about attention or memory, or you know, so do they need potentially some prompts to remember about some of doing some of those homework activities too, about how they could use reminders in their phone differently. Or have we also started at too big a jump? And as Sarah's saying, do we need to actually go back and just operationalise and break down things into even smaller steps? But I think too, not shying away from how important it is to actually get a benefit. So
focusing on it being a skill building, and unless you practice that skill, you're not going to learn it, and you're not going to be able to apply it.
Yeah.
You know, we know that if you do this, this helps, and it's going to really can learn as a therapist.
Great. This next question is a fantastic clinical question, I think. It says, do either of you have any advice on how to deal with parents that are anti-medication where the young person isn't responding to CBT? And where as a clinician you believe that medication is actually needed? I wonder if you've got any thoughts on that one.
Well, my immediate thought is to engage in sort of a shared decision-making process, really, where you know, you sit down with the evidence about what the risks are, because that's obviously what's going to be top in their head. So a really clear understanding of what the risks are. We know that antidepressant medication, there is an increased risk of suicidal ideation and behaviour, but it might be worth pointing out that in those trials, at least, no one's actually died by suicide. And then point out the benefits. So, like I said, there is a modest benefit of, you know, sort of similar effect size really for antidepressants, and you know, the clinical guidelines, you know, highlight that fluoxetine is, you know, is the best one to start with. And I guess the other thing, so in terms of risks and benefits, is that the risk of untreated depression actually carries an enormous risk of suicide. So sharing risk and benefit, but part of shared decision making is actually understanding the kind of preferences. So so they're clearly saying they don't want it, but understanding why. What is it that they're afraid of? You know, and
helping them to have the access to the right information in making that treatment choice.
That's great, and we've done a lot of work here at Origin on shared decision making. So when we post the recording of today's webinars, as well as some of the answers, if we don't have time to get through all of them, we're happy to post some references for people as well, just to understand how shared decision making works, and some of the tools that we've developed as well for young people with depression. Speaking about tools, one of our questions that came through, you were talking a lot about mood monitoring, and that young people often can just use their own phones for this. But are there some apps that have utility, or there's evidence that those apps are actually useful for mood monitoring as well?
Yeah, well, look, I mean, there's not a lot to be known actually about you know, complementing face-to-face therapy with online interventions by using apps. There's still a question mark, so I think that's where it's about the clinician knowing how to effectively use a tool, taking the time that you actually know all the features in a specific app, that you're aware of what it can do. Some of them now have, automatic sharing functions, and you might want to talk to the young person about privacy issues of, setting it so that they know that they can only use it for themselves. So I think just having that familiarity as a clinician before you recommend something that you know exactly how that app can be used. But there's plenty of free or very low cost that are very simple mood monitoring where they can just, throughout the day, they can set in some reminders to pop something in, that they might put in a couple of words about the context, like where they're at, and rate their mood, who they were with, rate their mood, that sort of thing, and it can also then collate things over the week, so it's easy to then look at things over the week in session together. So I don't think that we're at the stage where we can strongly recommend a specific app. We're certainly trying to do some work around knowing what clinicians use and what young people like to actually look at some recommendations, but then also the problem with developing apps too is that you can actually rate how usable they are, how acceptable they seem to be to young people, but then that big question of what's the evidence supporting their use is always left hanging, really. And we also don't know a lot about who develops the content in those apps. But for something like mood monitoring, because it's actually the young person inputting the information rather than working through in content that's been developed by people, it can be a pretty safe alternative to doing things in a paper-based way.
Or like we said, the notes section of your phone can be just as useful if you've talked about it and set them up in session to do that.
Yes. So, but if you want it, just if you search through the App Store, you can find it. You can easily find a couple of ones that are about monitoring or mood journals or things like that that can actually be useful. But I can't emphasise enough, I don't think, from some of the other work we've also done with feedback from young people about including technology in sessions, that the therapist, you really need to be familiar and confident with anything that you recommend and know how to use it, and show the young person in session. And then refer back to it, because just telling them to use something and then you never come back to revisiting its use or its applicability, they lose interest or and don't use it.
Definitely.
So staying on the phone issue, and I guess this goes to some of the challenges of working with young people in remote and regional issues. Is there any evidence, or do you have experience about doing the sessions that you've talked about today over the phone with young people? Or is the evidence predominantly face-to-face?
I think the evidence is predominantly face-to-face. There is evidence for the effectiveness of online CBT, so there are some CBT sort of programs that have been developed, there's been some robust research, the sort of research that we rely on that shows that it works. There's a lovely example called Sparks, which is they've used a gaming framework, and it's set to deliver CBT, and that was shown to be as effective as treatment in usual and child and adolescent mental health services where it was tested. So there's evidence for online. As far as phone-based CBT, there's not really been studies of that.
No.
But it is increasing. There are some text-based services beginning to emerge, and some text-based interventions being developed and tested.
Yeah, and some small evaluations of sort of real-time online counselling as well. So I think it will build, but at this point, what we know from the online work is the more the delivery of a distinct package rather than doing
in the real time.
Rather than recreating face-to-face online.
Yeah.
I can relate to the next question that's been asked, having done a bit of work with young boys. But do you have a sense of what is the youngest age for engaging in CBT, with boys in particular?
It's a good question. I think on the whole we can see that there does seem to be, in studies in particular, we do see pretty much an equal mix of the sexes in recruitment to studies, but clinically we do see that there tends to be more young girls than young males accessing services. But that's not to say that that's what they're able or willing to engage in. I think what we do, well, what I have noticed, so I can only talk about my own experience now rather than what's in the literature, because I don't think there's a lot that's been written about this, but that particularly for those younger males, 12, 13, 14-year-olds, that's when you actually do notice far more of that difference in that concrete thinking style and unable to think more abstractly, also perhaps more impulse-driven at that stage as well. So I think being more aware of those developmental influences in working with young people then, and to try to, for those younger males, to also to mirror that in the work that you do. So for you to try to be more concrete, more explicit, being really careful labelling of things and working through things quite at a slower or adapted pace for what they need.
So again, that sort of behavioural approaches to begin with, perhaps. You know, so you're still doing CBT, but it might be that you spend a bit more time on the behavioural kind of approaches, getting them active, getting them moving to start with.
Yes.
So this is maybe a related question. You were speaking about concrete thinking, but one of the registrants has asked, do you have some good strategies to help young people gain flexibility around fixated thoughts? And the example is a young person who's fixated on the thought that the world is a terrible place, for example.
I mean, I guess it's the strategy for introducing flexibility is slowly, and starting with those behavioural, you know, experiments and sending them out to do things, I suppose. You know, is going for a walk around the park and noticing the trees, and is that terrible? You know. But again, I guess it's just very slow work, and it might be that you can't shift that belief, but that you can introduce the possibility that that might be a belief rather than. So I guess it's metacognitive work, really, isn't it? It's also weighing up the pros and cons maybe of keeping that belief. That's sometimes a useful technique. Is okay. Well, you can sit with that and go with it, but actually, what do you want to get out of life? Where do you want to go? Where do you see yourself?
What does that belief stop you from doing?
Yeah, so how do we, so you can interrupt things that way as well. And again, that's a very behavioural kind of approach. Actually, where do you want to go, and do you want to kind of let that get in the way? You know, if you keep it, what is that going to mean? And if you kind of, you know, okay, it might still be there, but if you just kind of let it go through to the keeper, and you know, can you get on with kind of achieving the things you want to achieve?
With a specific thought, like the one that was mentioned in that example too, it got me thinking that, again, to also consider that the comorbidities as well. So is there an anxiety presentation that's also driving some of that thought? So thinking about doing some exposure work carefully and perhaps integrating that with the behavioural activation activities that you choose, so that they're designed to actually give that slow but gentle exposure to actually opportunities to see, to test out that belief that the world's dangerous, and to realise that there's times that they can manage that anxiety that is generated by that thought.
So, and again, you want to set them up with some coping strategies, or some relaxation, or some of those behavioural techniques, and also some psychoeducation. To overcome anxiety and fear, you have to experience a little bit of anxiety and fear. So there's a lot of prep work that would go into thinking about that and building hierarchies about what you're going to expose to, so you don't overwhelm them.
Absolutely.
On that note, I can highly recommend, and there have been a few questions about this as well, but the slide that you see at the moment, the manual is available to purchase on the Origin website. You can see the URL there, so origin.org.au, and there's actually a range of different resources Most of them you'll find under the skills and knowledge section of the website, but if you just search for the CBT manual, you'll be able to find that easily. And I think the beauty of it is, spruiking your sharp work, Alex and Sarah, it goes into all of those clinical examples with a lot of detail about how this actually works in practice. So you've been able to give us all today a fantastic overview of the modules. But for people that want to go a little bit further, the manuals are really designed to assist that day-to-day clinical practice. I really want to thank everyone. There's still well over a couple of hundred of you who have stayed for this session, which is a longer one. So that's brilliant. I think it speaks to the relevance and importance of the topic, and I like the sort of David and Margaret dynamic that we've had with our two co-presenters today. It's made it really engaging. We are at the end of the session. Just a reminder that all of the webinars in the Origin series are recorded, and so you'll be able to download at a later date the slides as well as the audio of Sarah and Alex presenting. There are still a few questions that unfortunately we haven't had time to get through. We will collate those as well as Sarah and Alex's answers to those questions, and we'll put those up on the website for you as well so you can see them. Just a reminder that the next webinar in our series is on good clinical care for young people with borderline personality disorder. It will be presented by Dr. Louise McCutcheon, who works in our HYPE program here at Origin, and it's on next Tuesday, July 28 at 12 p.m. Eastern Standard Time.